Good evening, everyone. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 8th episode of brand new Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshika, ma'am. Hi, ma'am. Thank you so much for joining, ma'am. And hi, Meenakshi. Thank you so much for joining today as well. And Anshi, ma'am, over to you. So, what is today's topic and who's our moderator, ma'am?
Thanks, Gomati. So, as we all know that we are doing a series on understanding the anatomy of the eye, and then with that each part, we will be discussing the diseases. So, today's topic, we have already done the previous session on the parts of conjunctiva. Today, we are going to talk about and learn and revise about conjunctival disorders and diseases. So, we have Lakshmipriya with us. She is my master student. I'm very happy. She's one of the brightest students when I had at SJSIO. So currently she's working as an optometrist in a hospital, and it's very nice when we have working current optoms seeing patients and who deliver or moderate the session because they give us a live example of what happens in practical. So thank you, Lakshmi, so much for joining us, and over to the MC for introducing Lakshmipriya.
Good evening, everyone. I am Rathi, a third-year Bachelor's of Optometry student at Dr. Agarwal Institute of Optometry. It gives me immense pleasure to introduce today moderator Ms. Lakshmipriya Srinath. Ma'am is currently working as a senior optometrist at Shiva Eye Care, where she manages clinical examination, contact lens dispensing, and spectacle dispensing. Lakshmipriya ma'am completed her master in optometry at Sankar Eye Hospital, where she built a strong foundation in advanced diagnostic and evidence-based practice. In addition to her clinical excellence, ma'am actively pursues research and academic development with a special focus on optometry and sports vision. Her current work involves assessing visuomotor reaction time in athletes to enhance performance-driven visual strategy. We are truly honored to have you as our moderator today, ma'am. Thank you so much for joining us. Now moving on the presentation. Our presentation for today is Ms. Padmashri, a third-year Bachelor's of Optometry student, a member of multimedia team and captain of Yellow Sports team at Dr. Agarwal Institute of Optometry. Ms. Padmashri, please begin your presentation.
Thank you, Vivi. Good afternoon, all. I'm Padmashri, a third-year student from Dr. Agarwal Institute of Optometry. Today, we're going to discuss about disease conditions of conjunctiva. So basically, what is conjunctiva? The conjunctiva is a transparent vascularized mucous membrane that lines the posterior surface of the eyelids and reflects onto the anterior surface of eyeball up to the lids. Anatomical subdivision. Palpebral conjunctiva eyelids, that lines the inside of the eyelid. Bulbar conjunctiva, which covers the sclera, and conjunctival corner is a junction between palpebral and conjunctiva meet, forming a sac-like space. The conjunctiva contains specialized glands like glands of Cross, Wolfram, and goblet cells, which helps in lubrication. It is highly vascularized and innervated, contributing to its protective and sensory function. Additionally, the conjunctiva receives blood supply from both peripheral and posterior conjunctival arteries and nerve supply, mainly from the ophthalmic and maxillary divisions of trigeminal nerve. Inflammation of conjunctiva. Inflammation of conjunctiva, that is conjunctivitis, is classically defined as conjunctival hyperemia associated with a discharge which may be watery, mucoid, mucopurulent, or purulent. So what are the categories? First one is infective conjunctivitis. The subtypes are bacterial conjunctivitis, chlamydial, viral, ophthalmia and granulomatous conjunctivitis. So the types of bacterial conjunctivitis are acute, hyperacute, chronic, and annular. So chlamydial conjunctivitis is trachoma, adult inclusion conjunctivitis, neonatal chlamydial conjunctivitis. So for viral conjunctivitis, it is adenovirus, EKC, TPF, and adenovirus conjunctivitis, molluscum contagiosum, and herb simplex. For ophthalmia neonatal, it is a separate entity affecting newborns. So granulomatous conjunctivitis is a paranoid oculoglandular syndrome. So infectious conjunctivitis. It is an inflammation caused by microorganisms and it is the commonest variety. This is in spite of fact that the conjunctiva have been provided with natural protective mechanisms reconnaissance in form of low temperature due to exposure to air, physical protection by lids, flushing action of tears, antibacterial activity of lysozymes, and humoral protection by the tear immunoglobulins. Bacterial conjunctivitis. Bacterial conjunctivitis is an inflammation of conjunctiva caused by bacterial infection. It is classified based on its severity and chronicity. Acute bacterial conjunctivitis, hyperacute bacterial conjunctivitis, chronic conjunctivitis, and annular bacterial conjunctivitis. What is the cause? For acute, it is Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenzae. For hyperacute, is Neisseria gonorrhea. And for chronic, it is Staphylococcus species and Moraxella lacrimata. For angular, it is Moraxella lacrimata. Clinical features. For acute, it is redness, purulent discharge, eyelid stuck on waking, foreign body sensation. For hyperacute, it is profuse purulent discharge, eyelid edema, hemosis, preauricular lip adenopathy. For chronic, it is persistent mild conjunctivitis with minimal discharge, foreign body sensation. Angular, redness at cancer, irritation, and swelling. So the pathology involves acute inflammation with polymorphonuclear infiltration in a conjunctiva, destruction of epithelium, and hyperemia. What is the differential diagnosis? It is viral conjunctivitis, allergic conjunctivitis, and trachoma. The treatment for acute is broad spectrum topical antibiotics, that is chloramphenicol. For hyperacute, it is systemic penicillin or ceftriaxone. For chronic, we should eliminate the cause first and treat with the topical antibiotic. For angular, it is zinc sulfate drops. Chlamydial conjunctivitis. It is conjunctivitis caused by Chlamydia trachomatis with distinct entity. Trachoma, adult inclusion conjunctivitis, neonatal conjunctivitis. So etiology. The etiology for trachoma is Chlamydia trachomatis serotypes A, B, BA, and C. For adult inclusion conjunctivitis, it is serotypes D2K. For neonatal, it is D2K via birth canal. Clinical feature. For trachoma, it is follicle, papillary hypertrophy, sinus formation, and scarring. For adult inclusion, it is follicles, mucopurulent discharge, preauricular limb adenopathy. Neonatal is onset after 5 to 14 days of birth with purulent discharge. Pathology. Chronic inflammation with lymph node follicles and partly leading to scarring. Differential diagnosis. Adenoviral conjunctivitis, bacterial conjunctivitis, and viral conjunctivitis. Trachoma. It is a chronic infectious eye disease caused by bacterium Chlamydia trachomatis, that is Serovas A to C. It is the leading infectious cause of blindness worldwide, primarily affecting populations in poor rural communities with limited access to water, sanitation, and healthcare. Pathophysiology. It is a repeated or chronic infection leads to inflammation and scarring of conjunctiva. This inflammation causes globule cell loss, leading to mucin deficiency and unstable tear film. Scarring causes entropion and pityriasis, which damage the cornea. Progressive corneal opacification and vision loss may result. Clinical grading. T is follicular inflammation, TI that is intense inflammation, T is that is scarring, TT is pityriasis, C was corneal opacity over mucin. Presentation. Recurrent conjunctivitis, that is follicular inflammation of upper tarsal conjunctiva. Globule cell loss, which leads to mucin deficiency, which results in dry eye symptoms. Conjunctival scarring and keratinization. Entropion and pityriasis in late stages, corneal neovascularization and opacity. What is the diagnosis? With a clinical examination using WHO grading scale and Vinicius stained conjunctival scrapings. PCR or ELSA for Chlamydia trachomatis in research or advanced clinical settings. Management. Mucin stimulating agents like topical ribamapide and diclofosine, not widely available in all countries, stimulate mucin secretion and globule cell proliferation. Vitamin A supplements. It may be oral or topical retinoids that improves epithelial and globule cell function in deficiency states. Anti-inflammatory therapy. Topical corticosteroids and cyclosporine reduce ocular surface inflammation, improving mucin production indirectly. Preservative-free lubricants, especially carboxymethylcellulose or hyaluronic acid formulations, to hydrate and protect mucin-deficient surface. Autologous serum eye drops that contain growth factors and mucin-like components that support healing, and epithelial health. Surgical intervention, mucous membrane grafting and amniotic membrane transplantation in severe cicatrizing diseases. These are the images. Adult inclusion conjunctivitis. It is a sexually transmitted acute follicular conjunctivitis due to chlamydia trachomatis serotypes from B to K, often associated with genital infection. It is a transmission, of autoinoculation from genital tract, swimming pool contamination. Clinical features. Follicular hypertrophy, that is in lower conjunctiva, mucopurulent discharge, mild photophobia, pre-auricular lymphadenopathy. It may involve superficial keratitis or panels. Diagnosis. Similar lab techniques as for trachoma, that is MJ stain, PCR, and ELISA. Treatment. Topical tetracycline or erythromycin. Oral azithromycin 20 mg per kg, single dose. Same strategy in trachoma. A stands for surgery, A stands for antibiotics, F for facial cleanliness, and E for environmental influence. Viral conjunctivitis. It is most viral infection affect the conjunctival and corneal epithelium, presenting as keratoconjunctivitis. Some primarily involve the conjunctiva, others the cornea. Types. Adenoviral conjunctivitis, epidemic keratoconjunctivitis, pharyngeoconjunctival fever, herpes simplex conjunctivitis, molluscum contagiosum conjunctivitis. The pathology. Follicular response with lymphocytic infiltration. The types are adenoviral conjunctivitis. The causative agent was adenovirus type 3, 4, 7, 8, and 19. The common features are highly contagious, bilated, water discharge. The key signs of adenoviral conjunctivitis is follicular reaction, pre-auricular lymphadenopathy, pseudomembrane corneal inflammatory. The treatments are cold compress, lubricants, mild topical steroids if corneal infiltrates are present. Pharyngeoconjunctival fever, that is it is caused by adenovirus type 3 to 7. The common features are associated with URTA and fever, and it is common in children. The key signs are conjunctivitis, pharyngitis, fever, follicles, preauricular lymphadenopathy. The treatment: lubricants, cold compress with algae. Herpes simplex conjunctivitis. The causative agent was herpes simplex virus, and the common features are it is unilateral, it is often follows HSV reactivation. Key signs are vesicular lid lesion, follicular conjunctivitis, dental ulcer with corneal. Treatment: topical acquired 5 times per day and avoid steroids. Herpes zoster conjunctivitis. It is caused by varicella zoster virus, and its common features are it is mostly affects the elderly people. It is a part of HZO and dermatomal distribution. Key signs are lid vesicles, conjunctival infection, keratitis, and uveitis. Treatments are oral acyclovir 800 mg 5 times per day, 7 to 10 days. Lubricants, topical steroids if uveitis is present. Molluscum contagiosum. It is caused by pox virus, and its common features are chronic follicular conjunctivitis in children. Key signs are undilated lid nodules, unilateral conjunctivitis. Treatment are lesion excision or cryotherapy. Ophthalmia neonatal. It is a condition that refers to bilateral conjunctival inflammation in newborns under 30 days old, commonly caused by infections acquired during or after birth. These symptoms include eye discharge, eyelid swelling, and conjunctival redness. Causes range from chemical irritation to infections like gonococcus, chlamydia, or herpes simplex virus. Early identification and treatment are essential to prevent complications like corneal ulceration and blindness. Prophylaxis include antenatal care, hygiene delivery, and postnatal antibiotic eye prophylaxis. Treatment varies by course, involving topical and systemic antibiotics or antibiotics. Paranoid's oculoglandular syndrome. This syndrome is characterized by unilateral granulomatous conjunctivitis, preauricular lymphadenopathy, and systemic symptoms like fever. It results from infections like cat scratch disease, tuberculosis, tularemia, and syphilis. So historically diagnosed based on clinical features, modern techniques now identify specific pathogens, making the syndrome's term somewhat outdated. Management involves treating the underlying systemic infection. Ophthalmia nervosa, that is caterpillar hair conjunctivitis. This condition is caused by retention of caterpillar hairs in the conjunctiva, leading to granulomatous reaction and a bulbar conjunctival nodule. Often occurring in summer, it may mimic tuberculosis histologically due to giant cell formation around the hair. The definitive treatment is surgical incision of lesion to relieve symptoms and confirm diagnosis. Inflammation of conjunctiva, that is allergic conjunctivitis. The types are simplex allergic conjunctivitis, vernal keratoconjunctivitis, atopic keratoconjunctivitis, giant papillary conjunctivitis, principular conjunctivitis, contact derm conjunctivitis. For herpes simplex conjunctivitis, the types are hay fever conjunctivitis, seasonal allergic conjunctivitis, perennial and allergic conjunctivitis. Vernal conjunctivitis is often chronic and it is also common in children. Atopic keratoconjunctivitis, it is typically associated with atopic dermatitis. Giant papillary conjunctivitis is often related to contact lens wear. Like Slictinular conjunctivitis, it is hypersensitivity to bacterial proteins. Contact dermatoconjunctivitis, it is a drop, induced or irritant contact. Allergic conjunctivitis, an allergic reaction of conjunctiva due to environmental allergens. So these are the types we have seen in the previous slide. So for simple allergic conjunctivitis, the causative agent was environmental allergens like dust, pollen, and smoke. Common features are mild transient itching and redness. Key signs are mild conjunctival hyperemia, artificial tears, cold compress, and antihistamine drop. For hay fever conjunctivitis, the causative agent was airborne allergens like pollen. So common features are associated with allergic rhinitis. Key signs are sneezing, nasal congestion, conjunctival redness. Treatment contains oral antihistamines, topical antihistamines. So for seasonal allergic conjunctivitis, the causative agent was pollen from trees, grasses, and weeds. And common features occurs in spring or summer, and it is recurrent. Key signs are bilateral itching, watery discharge, and redness. So the treatment options are mast cell stabilizer, antihistamines, and NSA drops. Perennial allergic conjunctivitis. So the causative agent was dust mites, pet dander, and molds. Common features are symptoms throughout the year. So the key signs are chronic mild redness, itching, lid swelling. Treatment options are allergen avoidance, long-term antihistamines. So vernal keratoconjunctivitis. Causative agent was immunoglobulin E that is mediated hypersensitivity in atopic individuals. Common features are it is seasonal, exacerbation, and intense itching. Key signs: a giant cobblestone papillae, rocky discharge, and field ulcers. Treatments are steroid drops and mast cell stabilizers, cyclosporine drops. So for atopic keratoconjunctivitis, the causative agent was atopy. And for common features are chronic and seen in adults with atopic dermatitis. Key signs are lid eczema, conjunctival thickening, and keratitis. Treatment options are topical steroids, trecolaminase ointment, and antihistamines. Giant papillary conjunctivitis. A causative agent was mechanical irritation like contact lenses and sutures. Common features are foreign body sensation, mucus discharge. Key signs are large papillae on upper tarsal conjunctiva. The treatment conditions are to discontinue irritant, change lens hygiene, mast cell stabilizer. So, PKC. It is a causative agent was delayed hypersensitivity to TB protein. It is testosterone. Common features are nodal inflammation and photophobia. Key signs: small white nodules near limbus with surrounding condition. The treatment available are topical steroids, treat underlying cause, TB, and for contact dermatoconjunctivitis, causative agents was cosmetics, topical drugs like neomycin. The common features are itching, lid swelling, associated skin involvement. Key signs: erythema, eczema of eyelids, and phimosis. Treatments are discontinue offending agent, topical steroids, and antihistamine. So these are the pictures. Brain papillary conjunctivitis. It is an immune-mediated chronic inflammatory disorder of superior tarsal conjunctiva characterized by large giant papillae on eyelids, inner surface typically seen in contact lens wearers or individuals with ocular prosthesis, exposed sutures, or pulping bulb. Types: primary giant papillary conjunctiva that is driven primarily by allergic hypersensitivity, and secondary JPC that is triggered by mechanical irritation, example contact lenses, prosthesis, sutures, and belts. Etiology: it is caused by a combination of immediate and delayed hypersensitivity with chronic mechanical trauma to the superior tarsal conjunctiva. Clinical features are redness, itching, FB sensation, mucus or ropey discharge, possible blurred vision, and lens intolerance. Signs include papillae more than 0.3 mm on superior tarsal conjunctiva, hyperemia, mucus pooling that is bilateral in most of the cases. Pathology involves chronic inflammation and trauma lead to conjunctival epithelial changes, hypertrophy of papillae, inflammatory cell infiltration that next inflammatory cells, vessel alteration, and possible scarring. Treatment: to eliminate mechanical stimulus, stop lens wear for 2 to 4 weeks. Change lens type, resume only with clean daily or RGP lenses. Ocular hygiene, improve cleaning and preservative-free solution. Medications like topical antihistamines, nasal stabilizer, NSAIDs, artificial tears, short-term topical steroids, and severe cases. Address prosthesis and sutures. Refinish or replace prosthesis and rotate or remove sutures. Inflammation of conjunctiva. That is cicatricial conjunctivitis. Types are ocular mucous membrane pemphigoid, Stevens-Johnson syndrome, toxic epidermal necrolysis, secondary causes. So for toxic conjunctivitis, it is caused by exposure to chemicals, medications, or irritants. The ocular mucous membrane pemphigoid. The causative agent was autoimmune disorder targeting conjunctival basement membrane. Common features include progressive scarring, symblepharon, dry eye. The key signs are conjunctival fibrosis, corneal shortening, keratinization. The treatment conditions are systemic immunosuppressants, lubricants, and surgical care. So, for Stevens-Johnson syndrome, the causative agent was hypersensitivity reaction to drugs and infection. The common features are acute blistering of mucous membranes, systemic symptoms. Key signs are pseudomembranes, eyelid ulceration, conjunctival necrosis. The treatments are supportive care, systemic steroids, IVIG, lubricants, amniotic membrane transplant. For toxic epidermal necrolysis, the causative agent was severe form of SJC, that is Stevens-Johnson syndrome, usually drug-induced. Common features are extensive epidermal and mucosal detachment. Key signs are similar to Stevens-Johnson syndrome, but more widespread and severe. The treatment available are ICU care, immunosuppressant, aggressive ocular surface protection. The secondary cicatricial conjunctivitis, the causative agent was trauma, chemical burns, chronic inflammation, and infections like trachoma. Common features: chronic conjunctival inflammation and scarring. The key signs include symblepharon, entropion, and pityriasis. Treatment are treat the underlying cause first, and then lubricants, surgical correction of sequelae. Stevens-Johnson syndrome. It is a rare, life-threatening mucocutaneous disorder, most often triggered by medications or infection. It involves a severe immune-mediated hypersensitivity reaction, leading to widespread epithelial cell death in the skin and mucous membranes, including the conjunctiva. Ocular involvement. In acute phase, conjunctivitis, membrane formation, corneal ulceration. In chronic phase, blood cell loss, conjunctival scarring, symblepharon, and severe mucin deficiency can result in dry eye, limbal stem cell deficiency, and blindness if not managed early. Common triggers: medications, sulfa drugs, NSAIDs, anticonvulsants. Infections like Mycoplasma pneumoniae, herpes virus. Ocular cicatricial pemphigoid. OCP is a chronic autoimmune subepithelial blistering disease that primarily affects mucous membranes, including the conjunctiva. It leads to progressive conjunctival fibrosis, goblet cell destruction, and ocular surface keratinization. Pathophysiology. Autoantibodies attack components of the basement membrane, leads to chronic inflammation, scarring, and slender drop formation. Ocular signs are in early stage it is chronic conjunctivitis, FB sensation, and mucus. In late stage, it is conjunctival shrinkage, anti-obliquoron, entropion, psoriasis, and dry eye due to mucin deficiency. Degenerative condition, pinky-color. It is a yellow-white triangular subepithelial degeneration typically on the nasal conjunctiva, and it is caused by chronic exposure to UV light, wind, and dust. Now, it is a non-inflammatory degeneration. Clinical features are usually it is asymptomatic, may cause irritation, dryness, or mild inflammation. Pathology. Elastotic degeneration of collagen and deposition of hyaline tissue in subconjunctival stroma. Differential diagnosis. Conjunctival tumor, carcinoma, or inflamed folliculitis. Treatment. Lubrication for symptoms. Surgical removal if cosmetic issues or severe irritation. Pterygium. It is a wing-shaped fibrovascular growth from bulbar conjunctiva onto the cornea. It is caused by similar risk factors as pinguicula, like UV radiation, wind, sand exposure. Clinical features are it may cause redness, irritation, visual distortion when encroaching cornea. Pathophysiology. Elastotic stage and fibrovascular proliferation with active limbal epithelial cells. Differential diagnosis. Ocular surface neoplasia, conjunctival scar. The treatment conditions are lubrication, UV protection, surgical excision if vision affected or causing discomfort. So this is the picture of pterygium and pellicula. Concretions. It is a small yellowish white calcified sebaceous concretion in palpebral or bulbar conjunctiva. So it is caused by degeneration and accumulation of epithelial debris, sometimes related to chronic inflammation. The clinical features are it is often symptomatic. It may cause foreign body sensation or irritation if lost or on lid margin. The pathology. This calcific keratinous deposits in superficial conjunctiva. Treatment. Usually none if removal is symptomatic like exposure or excision. Subconjunctival hemorrhage. Blood accumulation beneath conjunctiva from ruptured capillaries. It is caused by glaucoma, Valsalva hypertension, bleeding disorders. Clinical features are bright red patch on white of eye, usually it is painless and no vision change. Pathology. Extravasated blood under conjunctival epithelium. Differential diagnosis, clear redness from inflammation. Treatment, reassurance, results over 1 to 2 weeks. Investigate systemic causes if recurrent. Discoloration of conjunctiva. Normal conjunctiva has a thin transparent structure. It can show discoloration due to various local and systemic diseases observable through the bulbar and palpebral conjunctiva. Types and causes. For a red discoloration, it may be because of subconjunctival hemorrhage. For yellow discoloration, bile pigments because of jaundice, blood pigments because of malaria and yellow fever, conjunctival fat in negro patients. Grayish discoloration, it is due to application of kajal and mascara in females. Brownish gray discoloration, it is caused by argyrosis from prolonged use of silver nitrate for treating chronic conjunctival inflammation, most marked in lower form. Blue discoloration is an ink tattoo from pains, effects of manganese stress, pseudopigmentation in blue sclera and scleromalacia performed. Brown pigmentation. It is divided into non-melanocytic and melanocytic. Melanocytic, the endogenous conditions like Addison disease or ophthalmosis. In exogenous, prolonged lateral use for glaucoma and argyrosis. So, melanocytic pigmentation, that is conjunctival epithelial melanosis, it develops in childhood. It is stationary, no malignant potential, no treatment needed. So, subepithelial melanosis, it is congenital anomaly associated with ipsilateral hyperpigmentation of the face. And for pigmented tumors, it is benign nevi, precancerous melanosis, malignant melanoma. Clinical features are it is visible discoloration ranging from red, yellow, gray, brown to blue based on underlying cause. Cosmetic concerns in some cases. Differential diagnosis. Differentiate pigmented lesions from systemic causes. Differentiate melanocytic versus non-melanocytic pigmentation. Treatment depends on underlying cause. Epithelial melanosis, no treatment required. Other discoloration, treat the systemic cause if present. A cosmetic correction if desired. Tumors of conjunctiva. Tumors of conjunctiva may be non-pigmented or pigmented, range from congenital, benign, pre-malignant, and malignant. Classification of tumors. Non-pigmented tumors. Congenital. Dermoids. Solid white masses at limb west treated by simple excision. For lipodermoid, it is a soft, yellowish white movable masses, no malignancy. For benign, it is simple granuloma. It is polypoid growth post-surgery or trauma. Papilloma, polypoid near cancers, cornices or limbus. Fibroma, it is a rare soft polypoid growth. Pre-malignant is a bovine intraepithelial epithelioma, that is carcinoma in situ. Malignant, squamous cell carcinoma. It is nodular tumor invading stroma associated with ocular surfaces squamous neoplasm. Basal cell carcinoma, it may invade conjunctiva from lips. Pigmented tumors, benign, that is nevus or congenital moles, gray, brown, or black nodules near limbus. Precancerous melanosis, it is superficial spreading melanoma. It is rarely progressed but can invade. Malignant, primary malignant melanoma arises de novo or from pre-existing nevus, spread to liver or other organs. What are the causes? Due to intense UV exposure, aging, smoking, HPV infections, squamous cell carcinoma, history in head or neck, light complexion, xeroderma pigmentosa. What are the clinical features? Growth on conjunctiva, polypoid, nodular, pigmented or non-pigmented. Size increase, pigmentation changes, and ulceration. Differential diagnosis. Benign nevus versus melanoma. Papilloma versus OSSN or SCC. Treatment. Surgical incision for benign and malignant lesion. For cryotherapy to surrounding tissues post-excision. Topical chemotherapy, mitomycin for SCC. Radiotherapy reserved for cases where surgery isn't feasible. Enucleation or exenteration in advanced malignant melanoma. These are my references. Thank you.
Thank you so much, Padmashri. It was so elaborative and very well explained. Now I request our moderator to add your clinical inputs, ma'am.
Thank you so much, Padmashri, for a comprehensive and a clinical relevant presentation. She has covered mostly all the conjunctival diseases. To know about the conjunctival pathologies, we get to know about the parts and its layers so that we can interpret disease and its clinical management, for which she has given a beautiful recap. So I would like to contribute a few observations based on my experience and practice, which offers additional clinical reference to what has just been discussed. So the commonest we see in conjunctiva is conjunctivitis and dry eye. So differentiating between conjunctival inflammation involves patient history, symptoms, and signs. So if you take history, going back to basics, history taking has a vital role. So we can ask for onset, duration, exposed to allergens or infected individuals, uses of cosmetics or contact lenses. If we see symptoms, we can see lacrimation, gritty irritation, stinging, burning, etc. So we can see itching as well. Itching is a classical sign for allergic conjunctivitis. We can see pain, photophobia, and foreign body sensation, suggesting there is an association with corneal involvement. And also we can see discharges. Discharges, basically there are four types of discharges. One is watering. Watering we can see in viral, and second one is mucoid. Mucoid we can see in allergic. Micropurulent, we can see micropurulent bacterial or chlamydial, and plurulent. Plurulent is classically for gonococcal infections. And there are some conjunctival reactions to the particular diseases. So mostly there are 8 conjunctival reactions, such as corneal injection. What happens is the bulbar conjunctiva becomes red, leaving the limbal region, and we can see this in classically in bacterial conjunctivitis, and hemorrhages we can see in viral and bacterial, and there is chemosis, that is a hypersensitivity reaction. We can see membrane. Membrane, we have 2 types of membrane. One is um, uh, where we can peel out the membrane with leaving the epithelial intact, and other one is we have to peel out the membrane with the epithelial. In that part, there will be some bleeding and of course pain, and we can see those conditions in adenoviral conjunctivitis, gonococcal infections, and Stevens-Johnson syndrome, and some bacterial conjunctivitis as well. And we can see subconjunctival scars, typically in um, theatrical diseases and trachoma. We'll be seeing papillae and follicles. Papillae is classically for bacterial and allergic, and we can also see in contact lens induced, such as GPC, and sometimes in blood cysts also. Follicles we'll be seeing in viral and theatrical conditions. So it is critical as patient often removes excessive discharge prior to the examination. So diagnostic evaluation may involve a thorough examination, including the use of fluorescence staining, and to identify the potential underlying cause such as conjunctival infections and systemic diseases. So moreover, paying attention to environmental factors and ocular hygiene plays a vital role in preservation and uh, restoration of vision. So I would like to add some clinical highlights, especially findings in conjunctiva. So when it comes to unilateral conjunctiva, always perform a single or double eversion so that the lesions in the fornix cannot be overlooked. When it comes to viral conjunctivitis, it is an occupational hazard for our healthcare professionals. So preventive measures must be followed. When it comes to gonococcal infections or other chlamydial conjunctivitis, patient can refer to genitourinary department for screening as chlamydial infection and initiation of contact tracking protocol and all. When it comes to vernal keratoconjunctivitis, patient have an increased incidence of keratoconus. This has been proved in many studies, uh, actually, which is suspected due to the excessive rubbing of eyes, especially in pediatric population. So, going back to degenerative conditions, we have peduncula and pterygium. So, the pathological features, as you know, it is UV-based degeneration, but the pterygium grows over the limbus on the cornea. So, there is a fact as that more than 50% of the adult population in UTI, that is in Spain, has peduncula and dry eye due to the exposure of UV. Other 50% also have signs, but they are asymptomatic. So, due to the excessive exposure of UV and wind and dust, they have peduncula. People at that particular place often involved in skiing, hiking, and climbing sports, which makes them exposed more to the outdoor activities. In other hand, if you see pterygium, uh, when it is long standing, that is in older patients or chronically inflamed, you can actually see deposits in slit lamp. Looks like white chalky spots on the surface of the pterygium. So if you see pathologically, pterygium overgrows the epithelium. That is in the substantia propria, it actually grows. So the epithelium is thin. That is, it is normal size. Whereas in other disease affecting like tumor or conjunctival amyloidosis, we can see thicker epithelium, which helps in differentiating lesions. These things we can see in slit lamp itself. So a thorough clinical examination and targeted treatment based upon uh, causes are crucial. Managing can be surgical or topical medications. Talking about topical medications, the common medications that we use is for bacterial, we'll be using antibiotics. viral anti-inflammatory, allergic steroids, and malignant lesions or tumors, we can go for immunotherapy and chemotherapy. If it is fungal, use antifungal therapy. So whatever medication, topical antibiotic it is very important to clean the eyelids of discharge so that the medication can work properly. And self-medicating from pharmacy without the guidance of any qualified healthcare professional can lead to a significant risk and may cause secondary side effects as well. And if you see prophylaxis, using the drugs within the prescribed period must be recommended. See, if we see some allergic patients, they might have had allergy 3 months before, and it might reoccur again. They might have used the same vial which is open 3 months before. So it is our responsibility to educate them that we should discard the vial within a particular duration, otherwise it will be expired. And they should not share the eye drops among family members. So avoid using the patient's towel or other formats is recommended. So coming to a conclusion, the insights I have gained from my seniors and my patients have deepened my understanding far beyond the research of any textbooks. Last but not least, my sincere thanks to Anshi ma'am and the studious team whose passion and scholarly commitment made this Optometry YouTube series both inspiring and enriching. Thank you for the opportunity. It is a wonderful experience for me to contribute to you. Thank you so much.
Ma'am, thank you so much, ma'am. This means a lot to us. And we don't have any questions from the student side as such. If they post any questions, we'll get back to you, ma'am.
Sure.
Anshi, ma'am, do you have any questions for moderator, ma'am?
No, today I think it was superbly detailed from Padmashri's side as well as from Lakshmipriya's side. It was nice to know the diseases, a recap of the anatomy, and then clinically what we should not miss when we are seeing a slit lamp. So thank you so much, Lakshmipriya, for giving us that time, for your giving us the little nuances which a budding optom should and a working optom should not miss when we are seeing patients. So thank you so much, Lakshmipriya and Padmashri. Over to you, Gomati.
Thank you so much, Anshi ma'am. And Padmashri, great PowerPoint, Kana. Thank you so much. And Lakshmi Priya ma'am, thank you so much for joining with us today. We'd like to host you on another wonderful platform, ma'am. Thank you so much. Yes. So, dear audience, thank you all for your continuous support towards Optometry series. We have got 2 announcements for the day. As you all know, admissions are open. This is the admission season at Dr. Agarwal's Institute of Optometry. Admissions are open for fellowship in optometry and internship in optometry. So, for more details, get to the contact number. I'll be posting the contact number in the description box. The second announcement for the day is, as you all know, there's a collaboration conference coming up with the Loyola ICAM College, and it is called as ISVTEC. So it is based on technology, future technology in eye care. Abstracts are open for that. The deadline for abstract submission is this month end, which is 31st July. The conference dates are 24 and 25th October. So the registration details, everything will be given in the description box. You can check out for later. If you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you all. Thank you, ma'am. Thank you so much. Thank you, team.